Welcome, 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 YBP family. Thank you guys again for joining us this Juneteenth of 2023. Essentially, we have a very, very awesome gift for you guys tonight. We have an esteemed guest, Dr. Erica Louden, and she is a fertility specialist. I'm so excited. Got to do some snaps here. Yes, exactly. And as you guys know, my name is Dr. Janelle Lee Allen, here with YBP. We also have Dr. Anu Amadi. We also have Dr. Elaine Ainsley, and we have Dr. Elizabeth Johnson with us from our YBP fam. All right. As you guys know, before we get started, let's get the little housework out of the way. We're going to do our disclosures of conflicts of interest. Just so you know, we are not receiving any gifts or payments from pharmaceutical companies, biotechnology companies, health institutions, or any other private or public institution for today's event. This event will be recorded for educational purposes. By participating in the call, you are understanding that we will be giving potential published education evaluations. All the information shared here will solely reflect the views of the panelists, and this will include the panelists' research of nationally available information, as well as the panelists' own personal experiences. The views expressed in this video are not representative of our associated institutions. This is not to be taken as strict medical advice. All content, including text, graphics, images, and information contained on and or available through this platform is for general information purposes only. As always, please talk further with your doctor or qualified health physician for more information. All right. With that said, let us move into the meat of things. We have again Dr. Erica Louden. And Erica, if you, or Dr. Louden, we always go by our last names here, even though we know each other. But Dr. Louden, if you can, tell us a little bit about yourself, where you did undergrad at, where you were born and raised, med school, residency, and where you are now.
Absolutely. So thank you for having me. I am born and raised in Chicago, Illinois, Great South Side, Chicago. I attended the illustrious Clark Atlanta University, so I love my HBCU experience. I stayed there and did a graduate degree, did my PhD, went on to do a postdoc at Washington University School of Medicine, St. Louis. Before I was like, oh, I don't want to be bitten by mice. Let me go take care of humans. They don't bite us often. So I attended Wayne State University School of Medicine in Detroit, Michigan, where I did my med school, and then I stayed for residency in Detroit at Hutzel Wayne State University still, and went on to do a fellowship in reproductive endocrinology and fertility at Medical College of Georgia, also known as Augusta University. And now I am practicing back home in Chicago. However, because of COVID, the one benefit is I see patients in other states too. So I see patients in Michigan, Portland, Oregon, Seattle, Washington, and soon to be Washington, D.C.
All right. Well, I am so glad that you are able to expand your services and that reach so many communities. The field of medicine, again, just, always something that can expand, always something that we're trying to help as many people as we can. With that said, this is Juneteenth. This is the day that we celebrate the freedom of our ancestors, the fact that we had a whole population of folks who did not know that they were free yet, and for whom, thankfully, they were told finally a year and a half after the Declaration. So one of the topics we talked about earlier in the year is the fact that our ancestors definitely did not have at all times reproductive autonomy. And we define that as being able to say when they would have children and at what age and on their own accord. So this idea of discussing reproductive health and fertility is so fitting for Juneteenth, and it's definitely in remembrance of our ancestors. So with that said, why don't we move to our first kind of question about this topic of, well, infertility, fertility, issues with having children, is that even a thing in our community? Tell us the 411, give us 100.
Okay. Are you awesome? Definitely, from what you mentioned, like from the years of like slavery in that institution, we were bred to have children and do those things. So the stigma that we are hyper fertile, over sexualized, all those things have kind of lingered. And as a result, we have not been educated very well on our reproductive health. And so it's not true. It's actually known that about 12% of couples have infertility. And of that, Black women are the majority of us. We're twice as likely to be infertile, and we seek care less often or later in life when it's not too late, but it also definitely at that point is much difficult. So that is kind of like the issue that we've been trying to kind of raise the stigma that we don't have infertility issues, because the issue we've always find is that people always know, even myself, I have an aunt who had a baby at 48. Of course, I can have one at 48. That is not the norm, though. And that's something that we have to kind of be aware of. And fertility is not genetics. Just because your grandparents were able to have 12 kids does not mean that you can. And the thing
Mhm.
is that our environment is so much different. Our forefathers, even though they might have eaten pork and all those things, they were much more healthy, because guess what? They had to walk miles to work. We're driving, we're not exercising, our environments are full of pollutants. And so those things, we call them endocrine disruptors, are present, and that can affect our fertility. So what was true for our forefathers may not be true for us, and fertility is not genetics necessarily.
So I'm in family medicine. I see a lot of female patients. They come in with a variety of different underlying medical conditions. What would you say are like the top three causes of infertility in women in Black communities?
All right, we tend to like break it down in organ system silos. So the number one thing, though, I'm going to skip the organ one, is to say age is the most common thing. Most of my patients, a lot of our patients tend to come at 40, and unfortunately, probably 50% of those that are 40 and above are of minority descent. The other thing, though, when we talk about organ system things that are the reasons for infertility, it's usually tubal factor infertility, uterine factors such as fibroids, which are as we know, are more common in the minority community, Black women, and it is genetics about that part of it. Thirdly, it can be male factor, and then we have egg issues, which kind of goes hand in hand with age most of the time. However, when there's egg quality issues, it can be other things, and those other factors could be genetics.
Mhm.
Things like autoimmune disorders, it can predispose you to have an earlier diminished ovarian reserve. And then another, I know you only asked for three, and I'm giving you more than that.
That's okay. Give it
But
to us. Give it to us.
another category that's kind of new on the horizon is probably in the last 8 years is called oncofertility. We kind of put it under umbrella of fertility preservation. And those may be patients who had to have some chemo or radiation therapy, and they didn't get very good counseling that can affect your fertility. And we tend to put that under the umbrella in the past of oncofertility. However, even my rheumatologist colleagues use methotrexate and things that can affect your fertility. So now fertility preservation is anything that can iatrogenically we're giving you to help you with your overall health that can affect your fertility, which is another scope of practice now where we are trying to do multifactorial educating of our colleagues as well as patients so they can get an early head on it. If you know you're going to have chemo, radiation, some of these toxic drugs, you can preserve your fertility. And so fertility preservation is kind of the new thing on the horizon, because as I mentioned, age is one of those things. What we're seeing is most people are not starting their families till they're like mid to late 30s. That's a fivefold increase compared to like as recently as 1960s. So people are delaying childbearing for different reasons, and that's including that fertility preservation umbrella to take care of.
Hmm. And before Dr. Amadi, I know you have a question. I just wanted to know if we can break down some of these terms like ovarian
Sorry.
reserve. No, it's okay.
Mhm.
Talk to people about when do we as females, when do we get our ovaries? I think some people don't know that. And just also, I think there was one other word that you mentioned about, it's okay, it'll come back to me, but go ahead if you can
Okay.
just
Now,
start.
so as women, we are born with all the eggs we're ever going to have. So our ovarian development, not to be, these doctors know what I mean when I say the gonadal ridge was formed at 5 weeks, but I'm not going to go there with you. You had the most eggs you're ever going to have in your life when you were in your mother's uterus. You had like 6 to 7 million eggs. By the time we're born, we have 2 million eggs. And the studies now we know that we only have 500,000 eggs by the time we hit puberty, because unfortunately, Mother Nature, I always like to tell my patient, is a beast. She is not nice. I'm so sorry. Life is not fair. And she isn't. Because what happens, our eggs, even though they're there, they're going through the steady state process of atresia, which is another term for cell death or apoptosis. So we only ovulate 500 of those eggs that we were ever born with in our lifetime. Even in menopause, you still have eggs. There's 1,000 of them. However, that's when it's called diminished ovarian reserve, when they're not functioning, they're not healthy. Because think about them, they've been with you so if you were today 25, great. These are 25-year-old healthy eggs. You just hit puberty at like 15, 12. they are the best eggs you're ever going to have. 30, same thing. But as we're aging, every month at the beginning of our menstrual cycle, those little baby eggs we were born with go from a cycle. They're primordial follicles, and they go through a maturation of going from primary, secondary to antral follicles, and they ovulate. However, the issue is the machinery starts to work less perfectly as we get older, where we start to now pull extra missing chromosomes when that egg tries to mature. And so as a result, when it gets fertilized, if you have abnormal number of chromosomes, we are seeing higher rates of either you're not able to get pregnant, miscarriages, something we call aneuploidy, things like Down syndrome happen as a result. Or you can get pregnant and have that baby get to 10 weeks and find out there's something wrong, and you have to make that critical decision of whether you would keep that pregnancy or terminate, knowing that this baby may not survive. And if it does, it has lifelong health illnesses. That's the challenge that comes with age. But diminished ovarian reserve, I brought this up to say, we have all our ovaries, and every day, every year, we're getting less and less. You'll still have eggs even at menopause, but the quality is the issue with them, because they're not, even though we always hear black don't crack, right? But my good friend, Reverend Stacey Everett Dunn, she has this advocacy group called Fertility for Colored Girls. And she says, black doesn't crack, but your eggs does. Unfortunately, it's something we have not learned how to circumvent itself for, preserve your fertility if you're not ready to have family. And if you're having issues, talk to your doctor early, meaning you've been trying with your partner. If you are less than 35 and it's been a whole year of trying, you should seek help. If you're over 35, then the criteria is 6 months, because we know it's more challenging. 6 months, you haven't gotten pregnant. Talk to a fertility doctor, or your OBGYN is the first, or even your family medicine doctor can assist with these grassroots basic steps. So diminished ovarian reserve is just that. Usually it's associated with age. You're 40. However, there are women who are less than 40 who have less eggs, and we base that by your hormones. And we draw these 3 labs. We do an ultrasound, and if you meet the criteria of having, I don't want to get real technical because you might ask me about these, but
no, I was gonna say, hold on. She is such an educator. She is giving us the information.
I know I'm a rambler too.
I know. Hold on. So what I'm gonna do is let's kick it back to Dr. Amadi and let him ask his question.
Sorry, Dr. Amadi. I have a question though for Dr. Louden, just because she just mentioned it. So when we're talking about diminished ovarian reserves, I have heard this question pop up just among my girlfriends. Okay.
Mm-hmm.
Does being on birth control help?
What? I used to think, I thought that before I went to, you think you know everything because you went to med school. No, unfortunately, being on birth control does not preserve your eggs, because oral contraception, even though you are having estrogen, progesterone exposure, it doesn't necessarily prevent atresia, because you may not be ovulating, but those eggs are timed. If they don't get used, it's a use it or lose it phenomenon. If you don't utilize them, your body's dumping them.
We've been talking a lot about female infertility. So question is, there's a male component as well. So can we talk about the top causes of male infertility, and how would you work that up in those type of patients?
Absolutely. Yeah. So we always say it takes 2. Women always beat themselves. You don't know how many times I have women just I was like, I actually need your husband or your boyfriend to do this too, because it takes 2. So yes, male fertility accounts for always up to 50% of causes of infertility. And we say 50%, but it's really 20 to 30% of couples not getting pregnant are due to male issues. And the other 20%, the reason why it comes up to 50% is because sometimes we see jointly there is something female and male related. So that brings it up to 50% can be. But if you want to think individually, 30% of males in a couple can have male factor. So when the couple comes, we do a very detailed history, even for our males. I want to know, what's your health issues? Do you have hypertension? Because some of those meds cause decreased libido, and that may be why you're not getting pregnant. Are you on any antidepressants? Because SSRIs, which are selective serotonin reuptake inhibitors, can cause you to have some issues with libido and sex drive. Then I'm looking at family history. I'm looking at your birth history. Were you born with cryptorchism, which for patients, you want to know what that is? Your undescended testicle, because that can go back to, have you had an injury as a child? You were playing baseball and you got hit with a baseball in the testicles, and that injury, nobody really took you to the doctor to make sure everything's fine. Then we look at social history, social aspects for the male. Do you smoke, especially marijuana? Because marijuana is known to have a daily dose dependent effect on male fertility, meaning you can have low sperm, they don't swim, and the morphology is poor, and you can't fertilize the egg very successfully with those numbers. So we do look at our males, and it goes to obviously doing a detailed history, looking for things that can be risk factors. And then when I see them, the automatic, the basic workup is every male is going to get a semen analysis. To do a semen analysis, all it requires, and men don't want to do anything, but we ask them, please, come on, let's do this. This is you're going to make happy wife, happy life, right? So semen analysis, you just have to abstain from intercourse or masturbation for 2 days, but don't go longer than 5 days. And the reason for that is men make all of their sperm and it's stored in their testicles. I mean, made in the testicles and stored in their epididymis. So if you have a release like the day before you do your test, your numbers are going to be low. And we're like, oh, he's oligospermia, which means low sperm. And it really is that he just had a recent ejaculation that caused his numbers to be low. The opposite is true too. I don't want you to go more than 5 days, because if you go more than 5 days, you go in 7 days without intercourse or release, sperm can start to have morphology issues, and we diagnose you with something called teratospermia, poor morphology, and we're thinking there's DNA damage there. And that may not be the case. So it is something we educate our men about doing. When they do that, I always counsel that if we find something wrong, we're going to repeat this twice, because unlike women who are born with all your eggs, men make new sperm every 3 months. See, Mother Nature is just not fair and nice. A man can have babies well later into his life than a woman can. And so we do the 2 semen analysis. If one came back abnormal, just to confirm it. Then what are the reasons for those things? So hormones, like for us, FSH, follicle stimulating hormone, grows our eggs. It does similar things for men. If your FSH, when I look at it, super high, that means you're going through testicular failure. Your brain is trying to get something pumping and get some sperm made. So we look at male hormones when there's something abnormal. FSH, what's his LH, what's his testosterone? Does he have low testosterone? And by the way, men, do not take testosterone if you want to have kids, because testosterone for men is a contraception. It causes spermatogenesis to be arrested. So when I see results come back abnormal, I'm asking them, okay, are you taking testosterone? What are you doing? Please don't take it, stop it, and we can see if it recovers. But I'm rambling again, but you asked me about male infertility. It is a big, huge factor. It can account to up to 50%. Men should get semen analysis and hormonal evaluation. If it's something really abnormal outside of my scope, I can start gel medicines to get your testosterone up. But I have a counterpart urologist deal with testicular prostate issues for men. I have a colleague who will see them if they think that it's something more severe outside of I need to get their testosterone up so they can produce sperm.
This is perfect. You are doing great things. I mean, I had no idea about basically marijuana being an issue with fertility. That, and we don't have any labels on our now for many places legalize marijuana. So I think that is an interesting understanding. Wow, that is good stuff. Okay. With that said, we talked a lot about causes and risk factors, and you gave us wonderful things. So we okay with rambling. Tell us more. You let it bubble over, and then that way our audience can have lots of different questions that we can follow up with them on. And now I'm going to shoot it to Dr. Elizabeth Johnson so she can kind of talk about, well, what's the other half of that?
What are some of your treatments and management plans for your patients, whether male or female? I know a lot of us hear about in vitro fertilization, also known as IVF, but what are some of the other options that people may have?
Okay, so it kind of goes back to what was the reason we find for the infertility diagnosis. So if it's tubal factor, it's not a lot you can do about your tubes being blocked or hydrosalpinx. So for those situations, there is something you might find in academic REI centers, because there's older doctors who still have loops. They can go in and do novocannulations, reapproximate your tubes, so that you could try spontaneous conception after the tubes are repaired. We don't really recommend that a lot, because it depends on how the tubes were damaged, how much damage, whether it will be successful. So you have a high rate of ectopics or re-damaging the tubes. So most commonly, if it's tubal factor, the tubes are blocked, we're going to say go straight to in vitro fertilization and not fix those tubes. If it's something like hydrosalpinx, and what hydrosalpinx means is that you have dilated fallopian tubes, and that comes from things like pelvic inflammatory disease that did not get treated timely wise. endometriosis can scar your tubes and cause you to have hydrosalpinx. If you've had, unfortunately, if you need a surgery, you need a surgery, but surgeries can cause adhesions of scar tissue in your tubes. And if that blocks a band of area of your fallopian tubes, it now can be blocked off and fluid accumulates. So if you have a hydrosalpinx, you can't go straight to IVF. You can, but you're going to have to do one more step. And that other step is that tube that's damaged and has fluid has to come out. And the reason is that hydrosalpinx that has toxic fluids in it can cause a miscarriage. So I can do IVF and put your embryo in there. You will miscarry 50% of the time because that's embryo toxic. So the tube has to be removed so that you can have a successful pregnancy to go on. So that's tubal. If it's uterine factor, some people just have polyps and fibroids. So fibroids, there are 7 types of fibroid. I'm not going to belabor that. All you need to know is 3 classes. The ones that are on the surface of the uterus, which you call subserosal, submucosal, which are inside the cavity where baby lives, and those in the muscle called intramural. Those are like the general classification. Only one is known to cause infertility or subfertility are the ones inside the uterine cavity called submucosals. Those 100% your REI, your OBGYN should be telling you to take that out because it's mechanically an obstruction. Your embryo, if it's trying to implant, can't very well. If it does, you have a higher rate of miscarriages if you can get pregnant. So we tell you to take those submucosal ones out. Those other ones, unless they're like big or causing you bulk pressure and pain symptoms, you can kind of leave them alone and watch them. So that is kind of uterine factor infertility. Other uterine factor infertility causes are polyps. Polyps are really simple. You can take them out, and then I give my couples, I say, okay, let's try 3 months. If you want to try timed intercourse or intrauterine insemination, that is the least invasive because right now there's nothing with your ovary, there's nothing with your tube. We know you had a polyp, and maybe that was why you weren't getting pregnant. The third one for uterine factor is called Asherman syndrome, which is where you have scar tissue inside the uterus from, once again, if you've had a surgery that was too aggressive, because our uterine lining has 2 layers. It has a functionalis layer that we shed every month with our menstrual cycle, and it has a basalis layer. If that basalis layer with the stem cells gets damaged, it's kind of like glued your uterus together and it won't pop open. So women who've had, unfortunately, you may have had a therapeutic abortion or termination, and that's okay, but know that that is a risk. You had a septum repair because septums can cause miscarriage. Any surgery on the uterus can cause inflammation. And so a doctor should be guiding you to reevaluate after surgery to make sure there was no scar tissue as a result of that. But we can repair scar tissue within certain reason if it's not too much. Other things for uterine factor, as I mentioned, with septums or uterine anomalies, those can be a reason why women aren't getting pregnant. And some of those are treatable, and some of those we kind of just say, okay, we're going to get your MFM, we're going to do IVF, and you're going to have to see a high-risk doctor because you're high risk for preterm delivery, for example, having like a unicornuate uterus. So that's uterine factor.
What the septum uterus is also? The septum uterus and the FMF.
Oh, MFM. MFM is a high-risk OB doctor. So just like me, they went for another 2 to 3 years after OBGYN. They specialize in taking care of high-risk OB patients. So you have hypertension, diabetes, lupus. You have something where your general OB is a little bit going to be more complicated. You want a high-risk doctor to make sure that they're giving them some recommendation and guidelines to get healthy babies, healthy mom across that finish line. But a septum, the septum is where during uterine development, the uterus, their 2 horns fail to fuse in the appropriately and resorb that tissue. So there's tissue that's sticking down into your cavity. Kind of looks like a heart if you ever saw one. And it goes down, but how we diagnose is because there can be other things like bicornuate uteri that could look like that. We have to measure like the depth of the indentation. So if the indentation is like greater than is 1.5 or greater, going from the top of the uterus called the fundus, that's a septum. And it needs to be trimmed back or resected back to open up the cavity because that septum, that area, that tissue that's in the middle of the cavity going down, does not have good blood flow. It's not vascularized. So embryos, you have high rates of miscarriage with those or failure to get pregnant.
So you need to turn the uterus from looking like a heart to just looking like a straight oval. In some
not an oval. You know, we actually, our uterus inside looks like a triangle.
Okay, so you want to remove the heart and get to the triangle.
You want to remove the heart. And some women can have a mouth, something called an arcuate. It is similar to a septum, but it's not a septum because it's less, that little indentation is less than 1.5. That's a normal variant. We don't fix it because no study says it's linked to infertility or pregnancy related issues, but a septum definitely is high on the list.
Well, a follow-up question or point to the treatments and management discussion. Earlier, you talked about fertility preservation.
Right.
Oh, it's one of them days, but y'all
Yes,
know
that's right. Yes.
okay. Preserving it. And it's, as the pediatrician on the call, a lot of people don't think that fertility has anything to do with pediatrics. But like you kind of mentioned, it's very important that parents of children who are at high risk know that they're at high risk. So those who have received cancer treatments and things like that. What's the discussion that you would recommend to even like providers to have with some of those patients, like what their options are, especially when it comes to children, like
Great question.
parents with children,
Right, great question. I want to answer that, but I forgot to mention for egg issues for your infertility, if you're DOR, you can still get pregnant. But if it's becoming too hard, some people have to go to donor eggs if their AMH or ovarian reserve is completely almost diminished at a certain age. Sperm, you're going to IVF, and if it's really bad for sperm factor infertility, some couples have to do donor sperm and not even use their husband if there's no recovery of healthy sperm. So, and there's things like microtesting to get sperm. So there's a whole breadth of things of treatment options. But to get to the question on hand, as far as when you have pediatric patients who may be diagnosed with something that's going to cause sterility for them, fertility preservation has become great. The challenge we find with pediatric patients are if they are pubertal, we can help them because we can stimulate them and freeze eggs, right? But if they are pre-pubertal, you can't take them through an IVF cycle or egg vitrification stimulation to get those eggs. So we actually have, and it's no longer considered experimental, but now is definitely a treatment that's offered at like academic hospital systems, like for us in Chicago, Northwestern is one of the big ones, University of Michigan in Michigan, where you can do ovarian cryopreservation. So you take the cortex of that pediatric child, you talk to the parents, of course, but if they were to do it, you would take a cortex, because the cortex of the ovary is where your primordial follicles that you were born with are lying. And we take them into micro slivers and we do a method called slow freezing. We freeze that tissue. And when they become in remission, and maybe 13, we can transplant that back into their body. It can give, we're not doing it to give them estrogen, even though they may need some. We're doing it so we can quickly like stimulate and harvest some of those eggs for them so they can have children later on in life. The conversation that doctors need to have, and it's hard to do because obviously when you get a diagnosis that's kind of you're scared of, you're not thinking about it fertility, but it has to be something that you broach the conversation and say, this is required. Most of our kids are living through these diagnoses because our treatments have become great. However, the treatments unfortunately have some side effects. One of those side effects can be that a quality of life, because a lot of times people think having children is like, okay, that's optional, and it may be optional, but the CDC now recognizes infertility as a disease, just like diabetes or hypertension. So to avoid that outcome for children who are faced with the early diagnosis of something life-threatening, we do recommend you talk to, and you say our reproductive colleagues. We'll set up those consultations. There's a time frame we ask the pediatrician or any doctor who's making these diagnoses to give them, like, tell us, like, you plan on starting chemo in 2 weeks, because we move our patients who are life-threatening or having something they need to get done urgently can move very quickly. But once again, you can give them that initial conversation, and you let your local REI, who's going to be helping assist you, deal with the rest of that for you, to tell them what that procedure looks like, that process looks like, see if they're willing to go through it. That's the second step. The third step is, a lot of times, patients and parents worry about the cost. Oncofertility, there are some great grants out there for covering it, like Reproductive is a company that freezes eggs for cancer patients or tissue for very cheap, like $75. They just need a letter from their physician with the diagnosis, and that process is done. The Live Strong Foundation, thanks to Lance Armstrong, has money to help patients who have like cancer diagnosis get fertility preservation done for them. So there are so many resources. However, the guiding model, she's Dr. Teresa Woodruff. I'm shout out. She's now at University of Michigan, I believe, from Northwestern. She started the whole oncofertility. So you should have your oncologist or your pediatricians, your rheumatologist, because it's not only cancer, it can be any therapy that's going to cause fertility, maybe issues. You have them partner up with your local RE. You have a nurse advocate who's going to make sure the appropriate paperwork is like transmitting between the two offices so you can move quickly, because it usually is a sense of urgency for those kind of cases.
And tell us again the name of that organization one more time.
Strong was one I mentioned, Burner's Purse, which is like Reprotect. That's where you would store the cryopreserve, the tissue at for very cheaply. Um, those are the two top ones. There's Cade Foundation, and then your reproductive endocrinologist has like resources like the pharmacist. So MDRX is a pharmacy, like for example, that I work really closely for, and they do something called Reunite, where they get the fertility drugs for patients like at discounted rates. Because you want to take some of the burden and the stress, like I have this diagnosis and the last thing on my mind is fertility, but the problem is you don't want to get to the other side of that where you're cured, you're in remission. And now the thing that you thought you desired so much in life, you never focused on it. And now that opportunity is gone.
And I think you also mentioned one other resource, and I think it was Fertility for Colored Girls, or what was the
yeah.
name of it?
So who are they? Okay, that is Fertility for Colored Girls is owned or started, a nonprofit started by Reverend Stacey Edward Duns. She herself went through infertility and realized that like the Black community was so uneducated about this, their options and everything. And there's no marketing for us. When you go into these clinics, you're always going to see little Caucasian babies, and that's nothing wrong, but nothing's targeting us. Nobody knows how to relate. And so she created this advocacy group. And so there's grants that she gives out, like for women who are dealing with infertility. There's grants available that she's partnered with, like MD Serrano, which is a drug company, even like some of the fertility clinics. There's another one called Broken Brown Eggs. I love her. That's Regina Townsend. She had polycystic ovary syndrome, which is something that affects a lot of minority women, PCOS, where you don't ovulate. And so you can't get pregnant if you don't ovulate. And a lot of people just thought, oh, I don't have regular periods. That's it. And who wants a period really until you're trying to get pregnant, right? But you need to have it. If you're not having, that's something like, once again, you have to be proactive advocating, like, why are my periods irregular? Some people didn't even know they had PCOS and what that means. But nevertheless, that's another organization where she has grants, she has resources, they have support groups in like multiple states to help women and couples who are going through things. And I say couples again, because I don't want to leave out the gentlemen. Men need to freeze sperm too. We freeze sperm from those who have like testicular diagnosis of cancer. And even young boys who are like the boys, we are a little bit more challenged because unlike the girls, we can freeze ovarian cortex. Men or little boys, I call them boys, if they haven't hit puberty, we're still in the struggle trying to figure out how we can do preserve spermatogonia for them if they're pre-pubertal to help them later. Right now, that's still a challenge.
Wonderful. All right. Well, we have had a rich discussion here today. Thank you so much for all your expertise. We always like to kind of leave on maybe tell us 3 things that you always like to leave your audience with. Or, I think you've kind of hit on some of those things. You can also share with us anything that you feel like maybe we haven't touched on and that you've seen as a recent issue.
Wait, and before we do that,
sorry, Dr. Johnson.
Dr. Louden kind of, touched on it a little bit, but just for ladies out there or just families and they're doing family planning, ask questions, see if your insurance will cover things. They're just, you said this earlier in the discussion, that the Black and Brown community were kind of notorious about seeking help later. And coming in, and then we have this higher incidence of infertility for that reason. So, don't sit at home and think like, oh, it's just me, or how am I going to get this paid for? Ask questions. Other people are asking. And I know I remember in the office, I had a mother who was a bit older. Child was so cute. Love this little girl. And she was very open. He shared how, I did IVF and my insurance company, they paid for everything. And I was like, what? She was like, I had no idea until somebody else in the office told me. So she had everything paid for.
Yes.
It's just amazing. But anywho, that's all I wanted to say before we went.
It's amazing. And on that note, that's what I kind of like to know. Unfortunately, there's only 19 states in the union that require that if your employer has 500 employees and is based in the state you worked in, that they have to offer some type of fertility package. And so I encourage you to go to resolve.org. That's one of our national advocacy groups that has the list of the states that require that. Now, there are some loopholes, for example, like PepsiCo's here in Illinois, where their headquarters is not here, so they don't have to give insurance coverage here. So that's something to know. But as you said, like, There's 19 where you have covered insurance and you may not even know it. There's also some great companies, they do it and they don't have to. Like I've had, I love the government, love you government, but they don't give good coverage in the military for fertility. So I had a Navy recruit go and get a job at Starbucks because Starbucks gives fertility. She did that for 90 days, came back, I did IVF, she got her eggs because she had PCOS, went on to have her baby, and then of course lost, kept the job. But I mean, there are companies who don't have to do it and they are doing. It's kind of what you're saying as well, as that ask the questions, contact your HR. If your HR then call the insurance, it's a number on the back of your card. They will tell you what you do and do not have. And a lot of the fertility companies will, REI clinics will also, you give them your card, they will run your verification of benefits and let you know so you can know before you do your consult. Because my number one thing is be proactive. Nobody's going to take care of your reproductive health, as you see, because for years, like we've always preached, like, no, take this birth control. You better not bring a baby home. And then you find out when you stop this birth control at 35, you had diminished ovarian reserve that the birth control has been hiding. So I encourage you to be proactive, meaning if you know you are not ready to have children, you're not in a relationship, even if you're same sex, male, female, whatever it is, you can freeze, you can do fertility preservation. You don't have to be infertile to get assistance. And you can go live your fabulous life. And this is seen as your insurance policy. You may not ever need these eggs or sperm. You try naturally on your own. And if it's not working, guess what? You have these young, healthy egg sperm that you can use when it's difficult, because it only gets harder later in life. So be proactive, advocate for yourself. When I say advocate for yourself, you may not be ready to take this step, but you want to know what your ovarian reserve is or your sperm health. You can ask your provider, OBGYN, your family medicine, your internist. Like most of the time, I don't know about internists, but your family medicine doctor, your OBGYNs can definitely check your ovarian reserve. You want to know what your AMH is, anti-Müllerian hormone. All your little baby eggs you were born with excrete this hormone. This is how we say what your quantity of eggs are. So I can't tell you have 234,000 left, but at 34, if your AMH is 3, you have plenty of eggs left. If it's less than 1, we got a problem. It doesn't mean you can't have babies when it's less than 1, but it's definitely going to be a challenge and you don't have time to wait. Your FSH, follicle stimulating hormone, is one that has to be done on day 3 of your cycle. If that number is already greater than 10, that's a problem. The only time your FSH should be high that early is if you are already perimenopausal, but there are women who go through ovarian failure less than 40. And then an antral follicle count. They can do an ultrasound, see if, like, how healthy your ovaries look. We know what ovaries should be measured. And you know, like, typically how many follows little baby eggs we should be seeing that you're recruiting at the beginning of the month. So if your OBGYN, your family medicine doctor sees that something is not within the reference range, that's when they don't feel comfortable managing, they send you to an REI. And the semen analysis, a lot of people think because they just see ejaculate that you have sperm in it. That does not mean anything. That's just fructose and seminal fluid you're seeing. It's not sperm. So if you have issues like you've been with a partner, you haven't been getting pregnant, there's no problem with doing a semen analysis. You can ask your primary care doctor for like an order or referral. So proactive, advocate for yourself.
Yes, this has been so good. Thank you so much, so much, so much, so much. I mean, I'm sure people have been enriched by this discussion, so many things that we've learned. Again, we are all doctors, but we all have different specialties. So it's been enriching just as a gastroenterologist, to hear this conversation. I think that if anyone else, does anyone else have any last minute questions, anything that's creeping up? I think that there is one question that's actually creeping up in my mind. For some people who are in smaller towns, who are dealing with issues such as even like fibroid uterus, meaning like, very painful contractions or just endless bleeding. Is there, a role for, like we talked about, being proactive? In this case, they are already behind the 8 ball because they're having a lot of issues. They're in a small town that may not have the resources to handle their fibroid uterus outside of surgeries. I've actually heard of young folks having hysterectomies due to fibroid bleeding. And certainly they don't have a uterus anymore, but, their eggs may still be there. Is there anything that you would counsel someone in that kind of situation?
Yes, like if they have already had a hysterectomy, of course, they still can have families. you can do IVF, we get your eggs out. And then you unfortunately are limited to using a gestational carrier.
Right.
There are agencies, there may be family members who will volunteer to carry that pregnancy for you, is what to know. But if you are like before the hysterectomy, before that, I always seek, even though you may be in a small town, get a referral, like, because this, once again, advocate for yourself. And of course, you don't know what you don't know till it's too late. But ask questions. So I'll always seek a second opinion. So it can be within that same hospital system. Go somewhere else and see if they have something to offer you, because there are things like radio frequency ablation of fibroids where you don't have to have a huge myomectomy. It does take several treatments. Uterine artery embolizations. We told patients that you shouldn't get pregnant after doing those, though, because it can cause miscarriage. But there is something new on the horizon where they have these particles that interventional radiology puts in now, and it temporarily is there. And then after the fibroid is gone or shrunken off, now those little beads are not permanent. So then you can have a healthy blood flow to a pregnancy in the uterus. So I'm saying all this again, once again, is to advocate, get a second opinion if you're in a small town. Do not think that that's all you have to do, because most of those small town, not to knock, small town docs are great. They're keeping us alive, but don't take that as the final answer. Make sure that the second doctor says the same thing. Like, your only option is a hysterectomy, fine, but going off of one person's opinion when it's such a life-changing decision is not the correct step to take initially.
Wonderful. And I guess the only follow-up question I would say to that really quickly is gestational carrier. Are there any resources for people to look for that? I know you said family member, of course, but if they don't have the family.
If they don't have, their agencies, and there's so many. I will see what agency is in your area, but there's agencies that we call it vetting. They do all the screening process. So it has to be somebody, usually you want a carrier who's like gestational carrier who's 35 or younger. She has a proven uterus, meaning if she hasn't had babies yet, we're going to tell you not to use her. We screen them for alcohol, things, and drug abuse. We make sure they're perfect. And if they're a match for you, they have to be a match. You have to feel comfortable because this person's carrying your child for 9 months. Where do they live at? I had a couple who, they lived here in Chicago and their GC was in Alaska. I don't say to do that, but if you got money to travel to Alaska for the birth, by all means. You also want to know, like, your agency will help you with the legal stuff, because there's legal, some states is considered, even though that's your biological tissue, you have to do adoption paperwork, which sounds really weird. In some places like Illinois, that is your child and it's completely no legal issue. So you do want to know the legal ins and out, and a good agency is going to do all that for you, because guess what? It is expensive. And that's the other new thing, this is an expensive process. IVF can be, if you're not in a state where it's covered, having a gestational carrier is. But once again, these are medical related expenses. I always tell patients, you get to use this to write off your taxes at the end of the year, whatever you spend. I froze my eggs when I was in fellowship because I know I wasn't having no baby no time soon. And I took out a loan because I was in Georgia. I took out a loan for $8,000 and I paid that back. So know there are resources if it's not finding like it's really reasonable for you to do directly. Just seek the resources out, because there are so many. Even if you don't want to do alone, as I mentioned, there are grants out there. That's usually for infertility, not for necessary fertility preservation. GC, there are some for, depending on what your reason for your hysterectomy there or a loss of uterus. There's a group called MRKH, or A Beautiful You. MRKH stands from Meyer Rakantowski Kosterhaus. I mean, there are women who are born without a uterus, and obviously their destiny is that they will never carry a pregnancy. And so they have grants for a way. So if that's your situation, know that there's a grant for you to go through IVF and to have a GC in that situation. Sorry, I'm bringing up a whole lot of new topics, right?
No, you're doing a great job. I mean, literally, this is exactly what we want our community to know, stuff that they, like you said, they never asked, so they never would have known. And you're giving great examples and great resources for people. We will essentially do a listing of all the things that you just graciously gave us, this information and all these resources. I'm just going to bring it on home again. Thank you for this Juneteenth recording being available to us, being available to the future of our next generation and all the folks out there who are trying to plan for that. This has been such a great resource. You have given us so much. Thank you so much, Dr. Erica Louden.